All right, so I'm going to start off with a great question that's come to me during the week, just while you guys think about what you might like to ask, although I see there's already a couple in the chats there. And this one comes from Paige Hubbard, and Paige says, I'm swooning over the Pilates Elephants podcast and what Breathe are all about. Well, thanks, Paige. Much appreciated. I would love to take my next training in this route. I'm curious how you present these elephants in a studio when it comes to long-term Pilates practitioners and clients, those with a very consistent practice. I'm thinking about the head rest up or head rest down episode. So many of my clients do this automatic response to the bridging or short spine cue. I know there's no harm in that. Would you even recommend introducing the concept of keeping it up for the sake of flow or variety? Is it too stuffy to go into detail about how they can actually keep the headrest up? Really interested in how you take these progressive and thoughtful facts into a studio. Great question, Paige. So I guess I want a different, and I don't have this is not a factual question, so I don't have a factual answer, which is to say that I don't think there's one correct answer to this question. So here's my view. My position in the Pilates industry and Chloe's position is such that it's our mission, it's our stated mission to help people move fearlessly and think critically. So, part of that critical thinking piece is part of our vision, our mission, what we're trying to achieve in the world. I don't teach retail Pilates classes anymore. I taught 20 classes a week for a decade, but I taught my last class 4 or 5 years ago now. And so I'm in the position where it's not my job to give people a workout. It's my job to educate people. Moreover, our students come to us, pay us money and spend their time with us to learn stuff, right? So it's actually my duty of care. It's my obligation, I feel, to share with them the truth as I best understand it. And likewise, the listeners to the podcast, no one listens to it against their will, presumably. So if you're listening to the podcast, it's because you're interested in learning something. And so I feel, and as does Chloe, a strong obligation to present the truth as best we understand it. Whereas as a Pilates instructor, teaching a group of clients in a group reformer class or a group mat work class, I take the position that actually your job there is not to, teach your clients the truth. That's not what they've paid you their money for. Like if you asked all those clients in the class, like, why did you pay the $20 to be in the room here today? Right? I'm pretty sure not one single one of them would say, because I want to understand biomechanics better, right? What they would say would be like, I want to feel healthier. I want to get some me time. I want to stop, thinking so much all the time. I want to feel more energized. I want to be stronger. There'll be a whole bunch of reasons, right? But I want to understand, biomechanics of the neck more would not be one of them, I reckon. So I reckon if in that situation, it's kind of like, offering that kind of advice to people can be kind of like outside of the sort of unspoken agreement that you've got with them. It's like they've come to you, they've paid you money, they want to work out, they want to walk out feeling longer and taller and softer and looser and more happy and stronger and all of that stuff. But nowhere did they sign up for an anatomy lesson, And so if you give them an unsolicited anatomy lesson, or any other kind of unsolicited lesson, like even if you don't talk about anatomy, if you just start talking about systematic reviews or whatever, it's like, well, when did they ask you for advice on that? They didn't. And I mean, I'm sure you've been in the position of giving people unsolicited advice before, right? And you know how well that goes down. I mean, anyone who's got kids knows, telling people how the universe actually works, isn't an effective way to get them to change their behavior. So I guess, I would be circumspect about feeling the need to educate people. But I do feel that it is part of your obligation if you are an instructor who understands the science and the notion behind fearless movement and movement optimism, that it is part of your mission to help people move fearlessly, right? To help people feel free and empowered and autonomous in how they move their bodies. But I don't think that's necessarily the same thing as educating them. So I think, sometimes a little bit of sugar makes the medicine go down smoother. And sometimes you can kind of sweeten it a little bit without them noticing by, just some like little side comments that they can take or leave. I guess I would just basically say, if it ain't broke, don't fix it. I don't think it's worth making a big deal. It's perfectly safe for them to have their headrest down as well as to have it up. It's not going to break anything. I think it's not a matter of convincing the clients so much as it is. I think all of the other instructors in the industry, I think are to me, I feel like as an instructor, it is a moral obligation for every instructor to stay up to date with the best practice and best evidence and teach accordingly, right? And so as science evolves or understanding changes or best practice changes or whatever, I think it's the instructor's responsibility to keep up to date with that stuff. But I don't think it's their responsibility to pass it on to the clients as such. So I would, you could get playful with it if you wanted to experiment and explore. You could do some stuff with the headrest down that involved a full, like a rollover. So something like the overhead exercise on reform, where your hands are in straps, you're lying on the carriage, you do basically a full rollover with your legs, and you kind of do a jackknife-y thing with your legs and you roll down. So basically you're doing the full rollover position. And then after that, you could follow that with a shoulder bridge, right, with the headrest up, right, and point out to the clients that actually their neck's less bent in the shoulder bridge with the headrest up than it is in the overhead. Right? I mean, that might be something you could explore with them if you wanted to. So I guess that's my answer to that. When it comes to other practitioners, I think it's a little bit different. Like I said, I do think it's a moral and ethical obligation for every practitioner in any profession to stay up to date with the developments in their profession, right? I mean, if I go to the doctor, I want the doctor to give me the latest advice, not the 20-year-old version that they learned in school back in the day. Same with the dentist, the architect, the builder, the shoemaker, whatever. I want them to give me the current best, known way of doing it. And so Pilates instructors are no different in my view. So I think it is an obligation for every instructor to stay up to date, but I don't think it's each instructor's obligation to educate other instructors, which again sort of falls into the category of offering unsolicited advice, which, we all know how well that works. So I guess, what it depends on your relationship with these people. Some radical candor might work depending on the relationship that you have, or just, promoting stuff on social media, like sharing, a link to the podcast, a particular episode, or a study, or, following places like that are reputable, that might have influence with people. Things like, there are a bunch of places I follow on social media, like Physio Tutors and Physio Network, and there are, evidence-based medicine, evidence-based exercise. There are a whole bunch of kind of Instagram and Facebook folk who post really cool little evidence-based things, like little memes, like a little thing that says, hey, here's this thing you don't need to worry about that you thought you had to worry about. And if you just share some of that stuff, sometimes that can have, because then it's not you saying it, it's like someone more reputable saying it. It's like, oh, I'm not saying this, I'm just passing this on because I think it's interesting, sort of thing. Sometimes that can be less threatening for people. So I'm sorry if that's not a satisfying answer. I don't have a great strategy for convincing people of things that they're resistant to. So yeah, if you've got a follow-up question for that, I'd love to hear it. And now let's go to the chat. So Melissa says, is SI joint upslip a thing? What does it mean pelvis is out? Short answer, no, it's not a thing. So the SI joint is the joint between your sacrum and your ilium. Just happen to have one here. So here is the ilium. That's the name of that bone there. And that bone there is the sacrum. And the joint between those two bones is the sacroiliac joint. And you can see from the front, from the inside of the pelvis, you can see where that joint is there. So the sacroiliac joint is what's called a very stable joint. The inside of the joint is kind of corrugated. Okay, it's not a smooth, kind of like your shoulder joint is a ball and socket, your hip joint is a ball and socket. That's kind of obvious that those things are meant to move a lot. The inside of the sacroiliac joint is kind of this lumpy, bumpy, corrugated surface where the surface of the sacrum, the sacral surface, is mirrored by the lumps and bumps on the, on the iliac surface. So those kind of lumps and bumps kind of fit into each other, kind of like a lock and key almost. So in other words, the bony structure of the joint, like if we look at, say, look at it from the side view. So if here's the sacrum, right, and here's the ilium, right, and those are the two joint surfaces that go together. Well, the sacrum is kind of, lumpy and bumpy like that. And then the ilium has these kind of corresponding lumps and bumps. So it kind of locks in together, and that stops any kind of upslip or downslip, as it would be, and also, forwards and backwards slip. So that's one kind of aspect. The other aspect is that in the sacrum, you can see that from the top view here, the sacrum is wider towards the back and narrower towards the front. Right? I hope you can see that. I'm not sure if you can see it from this view, but basically it is narrower towards the front. In fact, you can see it quite easily from here because, look, the pelvis is wider at the front and narrower at the back, right? So it's kind of wedge-shaped. And if you look at it from top to bottom, it's also wedge-shaped from top to bottom, which is to say it's narrower at the bottom and wider at the top, right? So it's wedge-shaped from top to bottom as well as wedge-shaped from front to back, okay? And the kind of biomechanical function of that wedge shape is that as you stand on two legs, right, and if you imagine that kind of wedge-shaped sacrum here and those two iliac bones on the outside here, well, the weight, the ground reaction force comes up through your femurs, through your thigh bones, okay? In fact, let me get my skeleton. So the ground pushes, gravity pushes the ground up at you through your femurs, and then the femoral neck here is angled, okay? And you can see that the femoral neck is angled up kind of, like so, right? It angles up like so. And so both of the femoral necks angle up like so, okay? And what that does is that it redirects that ground reaction force, the push of the ground against your body, it pushes it up that way, right? So the ground pushes your pelvis, the two halves of your pelvis, right, up and in towards each other, okay? And if you now think about that sacroiliac joint, it's wedge-shaped, right? The bottom of the sacrum is narrower, the top is wider. So when it pushes when the ground reaction force pushes the two halves of your pelvis up, what it essentially does is it jams the sacrum down and the pelvis up, so it sort of jams that joint closer together. And if we think about that in terms of just a sort of simple diagram, well, here's your sacrum, okay? And here's your ilium, and here's your other ilium, and there's your hip socket. And there are your femurs, okay? And ground reaction force comes up through here and pushes that way, okay, which pushes that way. And what that does is it basically, and of course you've got the weight of your spinal column and your whole torso and your arms and everything from the top, you know, pushing your sacrum down, right? There's the weight of your torso there. So what's happening is the sacrum is getting kind of jammed down and the iliac bones are getting kind of jammed up. And because it's a wedge shape like that, the more weight and load you put through it, the more it jams closed. Does that kind of make sense? Like when you put a door stopper under a door and you kind of kick it in with your foot so it wedges in real tight. And the harder you kick it, the tighter it wedges, right? So this is what's called a self-stabilizing joint. And what that means is that the more load you put through it, the more stable it gets, right? So if you pile more bricks on top of your head here, right, that just jams it even tighter. Does that kind of make sense? Thumbs up if that makes sense. All right, so it's a self-stabilizing joint. The very shape of the bones means that the more load you put through it, the less mobile it is, right? But even that aside, okay, it's because of the kind of corrugated nature of the joint surfaces and because of the incredibly strong ligaments that bind this joint. So if we look here and we think about the ligaments, you know, that surround this joint, there's like really strong ligaments like all the way right around here on both the front and the back of the joint that are really thick and strong and rigid and have no give in them, right? And so that combined with the corrugated joint surface means that this joint basically doesn't move. And there are a number of studies where even when the joint's unloaded, so the classic test of sacroiliac joint movement is where you stand and lift one leg, okay, because then this leg is unloaded, so you're not jamming the joint closed with that weight, with that, you know, force going through the joint. And so the idea is like, well, whatever degree of movement you've got in the joint, it's going to happen when you do this, right? Because one leg is down and is being jammed closed and the other leg is up, and that's causing that half of the pelvis to rotate, you know, posteriorly. So there's a really cool study. I'll see if I can, actually I won't be able to bring it up because it'll take me too long, but it's called a radiostereometric analysis of sacroiliac joint movement, so words to that effect. And there are a few of these studies, and so basically what they did is they get people to volunteer for these studies. I don't know how, but they surgically implanted radio-opaque markers in people's pelvic bones, right? So it's basically a lead thumbtack, right? So when you take an X-ray of the pelvis, the lead thumbtack, you know, shows up, right? So basically they put the lead thumbtacks in the ASIS, you know, the anterior superior iliac spine, the posterior superior iliac spine, blah, 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 a few different places, right? Somewhere on the sacrum, whatever it was. And then, you know, after the people wake up and surgery, scar heals over, whatever, then they get them in next week and they stand them up in what's called a stereometric fluoroscopic X-ray. So it's a stereo, it's got two X-rays, right? It's fluoroscopic, and that just basically means it's a video X-ray. It's an X-ray video, right? So it doesn't take a still image, it takes a moving image. And then they've got these stereo video X-ray, and they get the people to stand up and hug their knee, right? Just what I just showed you. And then they're measuring the movement of those radio-opaque, you know, lead thumbtacks. And what they find is that this particular study was in people with diagnosed sacroiliac joint instability, right? And what they found was 0.02 degrees of movement in both sides, painful side, non-painful side, okay? 0.02, right? So do you know how many degrees in a circle? You know, if we did a complete circle, how many degrees that would be? that's 360 degrees, right? So if you're facing north and you turn east, that's 90 degrees, right? So if you're on the Autobahn in Germany, right, and you're doing like 220 kilometers per hour in your BMW 9 Series, okay, and you turned the wheel 0.02 degrees to the left, okay, 15 minutes later, you would still be perfectly in the center of the lane, right? 0.02 degrees is basically zero. You know, it is for all intents and purposes, it doesn't move. So, and if you've ever been to a dissection or done surgery or whatever, you know, like those things, those ligaments are incredibly tough, and people can be involved in horrible car crashes, you know, falls from trees, whatever, leg broken in 20 places, pelvis fractured in 12 places, sacroiliac joint still intact. You know, it's like, it's really, really freaking tough. It's a tough-assed old joint. So that's the really long answer. The short answer is no, and that was the really long answer, which is still no. And yeah, I'm sorry I don't have time to bring up that study, but it's a really cool study, and I'll post it under the recording of this video, a link to it, because it's got some cool images of the women standing in that radiostereometric X-ray, and it just boggles my mind. Who, like, imagine you're walking around college and you see an ad up, you know, volunteers wanted to have surgical lead thumbtacks implanted in their pelvis and then stand in a moving X-ray machine and get ionizing radiation. You get $20, and just imagine him thinking like, oh, that sounds like a fun thing to do. Anyway, so great question, Melissa. And so what does it mean to have the pelvis out? Well, it's this kind of a different, well, so pelvises don't go out, right? So that's what we just went through, is they literally don't go out, right? Like literally, if wild horses, you know, dragged your legs apart, you would break every joint in your lower body, right? But not your sacroiliac joint, okay? So they don't literally go out, but people frequently have the perception, the feeling, the subjective experience of them being kind of twisted or out of whack or whatever. And what is thought to give rise to that experience is that when you have ongoing pain in a body area, that area, the representation of that area in your brain. So in your brain, there's a what's called a homunculus, which is basically just like there's a particular part of your brain that is connected to your index finger. And there's a part right next to that in your brain that's connected to your second finger and your third finger and whatever. And there's a part in your brain for your nose and a part for your left buttock and a part for your right knee and whatever. And so when you have a sensation in your sacroiliac joint or your pelvis or whatever, that occurs in a specific part of your brain, right? And when you have, you know, ongoing pain in a body area, one of the things that happens is that area of your brain that is responsible for interpreting sensation in that area or generating sensation in that area becomes smudged, right? So our sense of like where that body part is in space becomes less accurate, less precise, okay? And sometimes it can feel like that body part's somewhere that it's not, right? Because that homunculus becomes kind of a little bit smudged, basically. It's like it becomes blurry. So that, you know, that's my understanding of the current thinking on why that sensation that people have is that like it feels like it's out, right? That's a real feeling, but I don't think it's actually, well, it's not related to it actually being out. It's related to the brain's kind of misinterpreting the signals that come from that area. And so you're getting a signal from that part of the pelvis saying, oh, it's here. And then you're getting a signal from the other side of the pelvis that doesn't hurt, right? Which is an accurate signal, right? Which is, oh no, it's actually back here. And so you're going, this part of my pelvis is here and this part of my pelvis is there. Therefore it feels out. All right. Andrea says, Raph, I have a few of my Pilates students who won't curl up with their hands in straps, etc. As I say, it hurts their neck or they have a sore neck. I gave them cues to try and alleviate this, but they don't want to do it. Any suggestions on this, please? I do ask them to do strengthening exercise with TheraBand at home, but of course, not many do. Great question, Andrea. So when you're lying on your back and you curl up and it hurts your neck, it's funny, isn't it, that we have such a double standard around the neck and we have a lot of fear around necks that, you know, when you curl up, does it ever hurt your abs? Yeah. I mean, that's like the point, right? I mean, if you do curl ups and it doesn't hurt your abs, you kind of think like, oh, that was kind of a lame class, right? But then we have this double standard where it's like, if it does hurt your neck doing the same movement, you think like, oh, that's no good, that's dangerous, right? And this isn't a criticism of the clients. It's just like, I think this is a wide cultural phenomenon that is, throughout fitness and health, industry, that we have this kind of illogical, opposite kind of set of beliefs around, it's good to feel pain in certain places and it's bad to feel pain in other places in it during exercise, so we could say like, oh, what about upper traps? It's not good to feel pain there, right? But, what about your butt? Oh yeah, it's a great place. Good. What about your inner thighs? Yeah, awesome. Feel pain in your inner thighs. Quads? Nah, not so much, because that means you're overactive in your quads. So we have all of these kind of good and bad, value judgments on, where we're supposed to feel pain and stuff. And the neck and the lower back are two places that we're like, as a general rule, we're kind of very, very, we have a high anxiety about feeling, discomfort in those areas. So, the reality is, for most people, what they're probably feeling is just like weak muscles trying to lift their heavy head, and that freaking hurts. And that's because you're out of shape, right? And so the way to cure that is get in better shape, and if you never lift your head up, well, you're never going to get stronger, and it's always going to hurt when you try and lift your head up, right? So the answer is not always leave your head down. Imagine if they came to class and you do push-ups and they're like, oh, this hurts. You're like, okay, don't do push-ups ever again, because then it won't hurt. It's like, that sounds crazy when we say that, right? But but we say it all the time to people in regards to curling up and their neck hurting, right? I mean, imagine if people were doing lunges in your class and you go, and someone says, oh, this is hurting my butt. You're like, okay, better stop then, And by the way, next time we do lunges, just you sit it out, because we wouldn't want to hurt your butt. So it just seems plain crazy when you say it in that context. So I would, and we also know from experimental evidence that for people with neck pain, the best treatment is neck strengthening, right? So this is for people that sit hunched over their computers all day going, oh, my neck hurts. We can do ergonomics, we can stretch them, we can massage them, we can give them dry needling, we can do all kinds of things. None of it really works a lot. Stretching works a bit. Everything else, like massage, feels good when you do it, but as soon as you stop, pain comes back. But strengthening, progressive strengthening, has a long-term benefit, has the most effect of all of those things. And so, yeah, the best thing you can do is strengthen them up. And so, this is a case where I think there probably is a case for educating people, but not so that they know it, but just so that they do it, right? So the minimum amount of education that you can get away with so they actually feel confident to give it a go, rather than them becoming raving advocates and going home and telling all their friends about how they should strengthen their necks. It's just like, okay, well, if you can give them a compelling enough case that they feel safe enough to give it a go, and then if they will just bear with you and trust you for a few weeks, what they'll find is it gets a lot easier. Right. And it stops hurting. and all of a sudden they'll be like, oh, I haven't been curling up for the last 20 years, but I could have just, 3 weeks later, I could have just fixed it, right, at any time. So, and that you might not have to educate them at all, right, if they have enough trust, right? And how do you build trust? You build trust by demonstrating to them and them perceiving that you care, you have their best interests at heart and that you understand. Right. And so if they feel heard when they say, hey, my neck hurts when we do this, and what's behind that is like probably anxiety, right? They're concerned. If my neck hurts, that probably means I'm doing something bad to my neck, right? And I'm worried about that. So if you can show them that you hear that and you understand it and you care and you have no fear about that because you don't think it's a thing that is worth fearing, okay, you might be able to bring them along for the ride without even explaining it to them, just by the fact that they trust you and you're saying, no, actually you're quite safe here. And if you just strengthen yourself up gradually over time, you'll find that pain will lessen and go away, right? You might not need to explain anything. Or you might need to repeatedly and gently, mention in class, hey, if we're going to do curling up here, and sometimes people's necks hurt in a curl up and that's normal, just like sometimes your abs hurt in a curl up and that's normal. Right? Just like sometimes your butt hurts when we do clams and that's normal. Okay. And the way to make your legs not hurt so much when you do clams is to do more clams so you get stronger, right? And the way to make your abs not hurt so much when you do curl-ups is to strengthen your abs. And the way to make your neck not hurt so much is to strengthen your neck. Now, but if you want to leave your head down, that's totally your call because you're the boss of you, right? And I'm not here to make you do anything you don't feel comfortable doing, right? So give them the choice. Yeah, that's my suggestion.
Thanks, Raph.
Okay, we have a question from Carly. And Carly says, I'm confused after seeing a physio for a sore hip that has been bothering me for a few months in the night occasionally. I know you've said physiotherapists are good for acute problems. If I've had this issue for a few months, then who is the best to see? I've been given some exercises, but after listening to loads of Pilates elephants, I can't help but be cynical, but then so confused, exploding head. Still loving the podcast. They're awesome. I wish I could retain all the information though, so I could back up my confusion with evidence. So when I mention things to the physio, I'm concise. The exercises haven't helped so far from the physio, and I do move and exercise and put load on my muscles and joints. After watching a video of your wife doing a 90 kilo deadlift on the Insta a while ago, I've been trying to get there. I'm only 80 kilos so far and can't imagine adding another 10 kilos for a while. All right, so the basic question here is, Carly, you've got hip pain that's been bothering you at night sporadically, and you've been given some exercises, and so far the exercises don't seem to have helped a lot. Physios are great for acute injury. So, if you sprain your ankle, whatever, like that would be the first place I would go, would be a physio. They also can be great for chronic conditions, but it depends on the physio, right? So just like it depends on the hairdresser and it depends on the chef and whatever. It's like not all chefs are created equal, not all hairdressers are created equal, not all physios are created equal. And so I think physios are great for ongoing conditions as well. And so the pain, you're getting pain at night, it doesn't seem to be related to activity, which suggests to me that it's not a strength issue. Like if it was a strength, if it was a strength issue, I would expect that there would be a particular activity that required a lot of strength, that when you do that activity, it hurts. Like running or going downhill or lifting your shopping out of the car or something like that. And in that case, strengthening I think would be probably something that would, help a lot with that. But lying in bed asleep and it hurts, like that's not an activity that requires any degree of strength or endurance or flexibility. So, kind of just from a basic logic, kind of physiology standpoint, it seems to me like it's probably not a strength issue, which is not to say that strengthening isn't useful, because strengthening has so many other benefits. And so I deeply subscribe to the idea that you can't go wrong getting strong. So I wouldn't want to discourage you from doing strengthening work, but it seems like in this case, that's not the specific, solution to this problem. So if, we know that pain is multidimensional or multifactorial. And what that means is that pain can generally not be explained by any single cause, right? So when we look for the cause of pain, that's probably not the right question to ask. It's more a case of looking for the contributing factors. What was the combination of things that together, resulted in pain. And examples of this are abundant in, every area where we have pain. So that, when we think about something like disc bulge, well, there are lots of people who have a disc bulge and have pain, but there are lots of people who have the exact same disc bulge but don't have pain, right? So disc bulge seems to be part of the recipe, of what contributes to back pain, but you can equally have a disc bulge without having back pain. So it must not be the only, necessary ingredient there. And even if you think about something like bumping your leg on a table as you walk past it or something like that, well, it's very possible to get a bruise and then get undressed at the end of the day and notice in the mirror, oh, I've got a bruise. Where did that come from? Right. Well, that's an injury, but you didn't feel pain at the time. And so even just having an injury like that doesn't always result in pain. Right. So pain is this sort of multifactorial thing. And we know that, some of the factors that commonly contribute to that are things like sleep. Right. So if you don't sleep as long or as deeply as you need to, like basically you don't wake up refreshed, okay, we know that enhances the sensitivity of your system to pain. So, we know this from experiments where basically, again, this is one of those experiments that you think, who the hell volunteers for these? It's just like a sleep deprivation pain tolerance experiment, $20. And you come into the lab and we get, two groups of college students come into the lab, and one group gets to sleep through the night and the other group gets woken up after 4 hours, right? And then in the morning, everyone sticks their hand in an ice bucket and all the ice buckets are the exact same temperature, right? And then we ask them on a scale of 1 to 10, 10 being the worst, like how painful is that? And the people who slept less rated as more painful, right? And we repeat that experiment with a bunch of, like sticking their arm with a hot thing or pinching them or electric shocks or whatever. And we always, when we pinch them, we use precise instrument to pinch them the exact same amount of pressure. We use the same temperature of hot thing on them. We use the exact same voltage of electric shock on them. And the people who either had less sleep or who had interrupted sleep rated as more painful. So sometimes we let people sleep for the whole night, but we just wake them up every 2 hours. Then we let them go back to sleep again, right? So they never really get into a deep sleep. Then in the morning, guess what? Ice bucket hurts more. Right. So we know that sleep has an influence on pain. And we know a whole bunch of other stuff like anxiety has an influence on pain. Depression has an influence on pain. So, if we bring a whole bunch of people into the lab and we give them some kind of validated questionnaire that measures depression, right? It'll be something, basically it'll just have questions on this, from strongly disagree to strongly agree, right? How much do you agree with the following statement? I'm feeling kind of flat. Life has lost its savour. I don't enjoy my usual activities. I feel hopeless. No one loves me, And guess what? The people who score higher on that quiz, right? Ice bucket hurts more. Okay. And same with anxiety. We can give people questionnaires that measure anxiety and other aspects of mental health, right? So we know that poorer mental health correlates with greater pain sensitivity. We know that poorer sleep corresponds with greater pain sensitivity. We know that other social factors correspond with pain. So things like if you're undergoing workers' compensation claim, the ice bucket hurts more. Okay, or more to the point, actually, people on workers' compensation claims, their back pain is more disabling and they rate it as more painful. They use more drugs, they have more surgery, they take longer to recover. So, so we know that, and that's not to suggest that people are malingering, right? It's like these things just have some kind of effect on pain. And so the totality of all of these things, either results in pain or not. And of course, one of the factors is the status of the tissues, right? So if there's something going on inside your hip, that maybe there's some inflammation there, or maybe, who knows what's going on in there, right? Might be one of the factors. But having said that, whatever is going on inside your hip, it's very likely that there's 100 other people who've got that exact same thing going on in their hip without any pain, right? So, and just as there are probably 100 other people who didn't sleep well who don't have pain, right? So it's not the case that having some kind of thing going on inside your hip causes pain. It's not the case that having a bad night's sleep causes pain. It's just like sometimes I think what the best thing is a metaphor, right? There are a couple of metaphors. One is the cup, right? It's the cup of resilience, okay? And this is basically just a metaphor of like, well, how much, we all have like shit happens in our life, right? We always have, your mother-in-law comes to stay, taxes are due, kids are off sick, you don't get the raise at work, whatever it might be, right? So if you pour some stuff into into your cup, right? Maybe that's poor sleep. You know, you have a few nights of bad sleep, or maybe you've got a young child and you're not sleeping well at all. Or maybe you're depressed and you're not sleeping well, or maybe you're stressed and you're not sleeping well. Whatever, you're not sleeping well, right? And maybe there's some stress going on in your life. You know, maybe it's financial stress, maybe it's marital stress, maybe it's work stress, maybe it's whatever. Okay, then we pour in some maybe other stressors like low physical activity. You know, you're not very active. Then we pour in another, stressor like maybe your diet's not that great. You know, whatever. Okay, and then we could pour in 101. Just the things that make you stressed, right? Physically stressed. Okay, we could pour in 101 things in there, and eventually, sometimes the cup gets full, right? And then if you keep pouring in more stuff, well, eventually it overflows, right? And the overflow can be pain, right? And of course, another thing that we might pour into there, okay, might be like inflammation, or arthritis, or whatever. I've written the same thing twice, right? Because arthra means joint, okay, and itis means inflammation. So arthritis just means inflamed joint. So if I said inflammation or arthritis, it's like I just literally said the same thing twice. So anyway, if you pour all of that into your cup, and then if the cup eventually overflows, well, and the overflow is pain, well, which one of those things caused the pain? Well, no one of those things caused the pain. It was the aggregate of all of those things. And the good news is you don't have to get rid of any one of those to get rid of the pain, right? All you have to do is pour a little bit less into the cup, right? So the cup doesn't overflow. And that could be, hey, I'm just going to fix the sleep thing, but I'm not going to address anything else, right? Or it could be, hey, I'm just going to fix the physical activity thing. Or, hey, I might not fix anything, but maybe I'll just make a slight improvement to a few things, okay? Just enough so I'm just not pouring quite as much stuff into my cup, and so I can, not overflow the cup. So I think that's a pretty good metaphor. And so if I were you, Carly, I would think about those things in your life, basically all of the things that, we'll think about it as the things that make you build resilience and flourishing as a human, so what puts you in good health mentally, physically, and spiritually, right? Well, exercise, good diet, sleep, relaxation time, contribute a sense that you're making a meaningful contribution to something larger than yourself, we call it religion, call it meaningful work, whatever you want to do, close supportive social relationships, time in nature. For you, it might be having a bath with candles, or maybe a glass of wine with your loved one every night, or going for a walk with your dog. What are the things that, uplift you? Okay. Do more of those. And what are the things that sort of wear you down and make you unwell? Okay. Well, they're kind of the opposite, right? Not exercising, not eating well, not sleeping well, not spending relaxation time, not connecting with people you care about, not a sense of meaningful contribution, right? Well, the more of those you do, the more run down you become, right? Mentally, physically, and emotionally. So I guess I would suggest that you think about, when this pain started, what was going on for you, and have there been any changes in the balance? But because we all have shit that happens in our life, right? There's no one here who's going, oh, my life's perfect, I have no stresses, everything's amazing, right? There's always some good and some bad, right? And that's normal. But it's just when the good and the bad become imbalanced, that's when, the healthy and unhealthy behaviors or situations become imbalanced. That's when there's a problem, right? So if you just think about, has that balance kind of got out of whack a bit for you? And if so, what could you do to just bring it back just into balance, right? You don't have to eliminate the bad and make the good 100%. You just have to just stop overflowing the cup so much. So that might be sleep, or it might be, any one of those other things, or it might be a little bit of all of the above. And we've got a tool which I'll post in the show note, in the description under this recording, that basically is a self-questionnaire that basically takes you through all of these factors, and you just kind of get to self-rate. Okay, how's your physical activity? How's your relationship with your significant other? How's your sense of contribution and meaning? How's your, sense of fun? How are you sleeping? Blah, blah, blah. And then it works you through a little work exercise where you get to think about, which ones of those things might be most useful or possible for you to make a change. So I hope that helps. And what do you do with your physio? I think, well, if the physio is not helping, I would fire the physio, with love and respect. But it's like, well, why are you paying $100 a session if you're not getting the result? So, and that's not it. I don't think you should never go to physios. I just think, like, if that particular treatment's not working, why continue it?
Just a 10-minute check there, Raphael.
All right. So I think we've probably got time for one more, seeing as I do take a while to answer each one, which I hope is useful for you. So if you have, there's nothing in the chat right now. So if you have anything, now's your chance. And one of the things that sometimes people say to me is like, oh, I think this is probably a really stupid question. And let me reframe that there are no stupid questions. Like, we're here because, like, we can just talk about whatever here, right? So if you're embarrassed to ask it, that's probably a really excellent question, because probably everyone else has that same question but is also embarrassed to ask it. So, don't worry about, stupid questions. Janelle says, I've emailed mine. Did I receive it? I probably did. It's probably gone into the bottomless pit of my emails. I can't see it here on my list though. Can you recall what it was, Janelle? Can you type it in?
Just trying to. Sorry, it won't let me post it.
Or you could just unmute and tell me about it.
Yeah. So essentially, I did my clinical studies with you. If a client's coming to us with multiple injuries, for example, shoulder bursitis, shoulder impingement, and muscle tears around the shoulder, if we're trying to respect the muscle tissue healing time for the tears, what's best practice then to keep the joint moving for the bursitis and impingement so we're not leading on to frozen shoulder in time?
What a great question. All right. So were those things, was there an acute traumatic injury?
Yes.
Do you know what the nature of the injury was?
Yes, I'm using myself as an example to learn about these things.
Okay.
A very heavy child jumped out of my arms towards the floor and caught it on an angle first thing in the morning before the joint was warm.
Okay. And so kind of pulled it down at an awkward angle or that kind of thing? Very
awkward angle, and 12 kilos loaded very quickly.
Okay. And how long ago was that?
3 weeks ago. So not having much faith in Pilates, in the physios that I've seen. Scan reports have come back with that. But again, keeping an open mind to maybe that's not totally the cause of pain. But keeping all that in mind, I've been loading it lightly, going to classes and just keeping the load light, but weight bearing through the joint, trying to mobilize the joint as much as possible. But it doesn't, it's progressing, but I don't know if I'm actually applying all the things in the right order at the right time.
Okay. So a bursa is a little pad that sits in between a tendon and the bone that it crosses over, and prevents friction. So essentially a bursa is like a little plastic sandwich bag, okay, that's sealable, and it has a tiny, like a quarter of a teaspoonful of water in this, little sandwich bag. And then the sandwich bag sits here. And imagine these are the two halves of the sandwich bag with this kind of like one molecule thick layer of water in between, okay? Well, basically the water just eliminates friction. So the two halves of the bag can slide over each other essentially with nil friction. Okay, and so then, of course, the tendon, is underneath or above, and then the bone is on the other side. So it just allows the tendon to slide over the bone with essentially zero friction. So that's the purpose of bursas or bursae. And you have basically anywhere you have a joint in your body, you have multiple bursae, right? Because tendons cross joints, that's what they do. And so every time a tendon crosses a joint, you've got a bursa there. So you've got, a bunch of bursae in your shoulder, and one of them's called the subacromial bursa. And the acromion is this bit here, that the little roof of bone over the shoulder. And you can feel that on yourself if you just put your fingers on the outside of your shoulder. You feel like a tiny little bony bump on the outside. That's your acromion, okay? And if interesting bit of trivia, if you walk your fingers back, you'll find that acromion turns into your shoulder blade, right? It's the part of your shoulder blade. So the shoulder blade, the acromion is just the pokey outy bit of the shoulder blade that overhangs your shoulder joint, right? It's a little roof of bone over the shoulder joint. And underneath the acromion is the subacromial, underneath the acromion, subacromial bursa, right? And then underneath that bursa is underneath that bursa is the tendon of the supraspinatus muscle. And the supraspinatus, so actually, this is good. We can find your acromion, walk your fingers back to the scapula, okay? Well, that bony ridge along the scapula is called the scapular spine. Spine just means bony ridge, right? So it's just the bony ridge of the scapula. And above the bony ridge, above the spine, is a fossa, a shallow depression, okay, called the supraspinous fossa, right? Supra means above, spine, bony ridge, fossa, shallow depression. So it's literally the shallow depression above the bony ridge on your shoulder blade, right? And in the supraspinous fossa is a muscle called supraspinatus, right, which is one of your 4 rotator cuff muscles. And the supraspinatus muscle has a tendon that goes out and continues under the acromion, right, and then goes onto the head of the humerus, the arm bone, okay? And so the tendon of the supraspinatus is in between the ball of the shoulder joint, okay? It's above the ball of the shoulder joint and below the acromion. So it's kind of sandwiched in between there. And you've got a bursa on top of the ball of the shoulder joint, underneath the tendon. You've got another bursa underneath the acromion, above the tendon, right? So it can slide freely without catching. And if you're, there are 2 situations where that bursa can become itised, right? Remember, itis means inflamed, right? And how do we know it's inflamed? Well, you generally do an ultrasound or an MRI or something like that, and they see that it's bigger than they would expect it to be, right? Just like when you look at your finger and your finger's bigger, you think, it's inflamed, it's swollen, right? Well, same with a bursa, right? Same with your liver, same with whatever. It's like if it gets bigger, we think, maybe it's swollen, okay, maybe it's inflamed. But there are 2 situations where a bursa can become bigger, right? And we know this from research on swimmers, because you might have heard of something called swimmer's shoulder, where they do a lot of overhead work and they get sore shoulders sometimes. And so, we find that swimmers who just have no shoulder pain, right, have enlarged bursae in their shoulder, right? Why? It's not inflamed. It's just like a callus, right? I mean, if you do a lot of yard work with your hands and against a shovel, right, your skin will become enlarged, right? But that's not an injury, right? It's not inflamed. It's not an itis. It's just a natural adaptation to resist the load that is, to deal with, to accommodate the load that it's put under, right? So swimmers who use their shoulders a lot have enlarged bursae and no pain. But when the swimmers have an acute injury, right, and they have an enlarged bursa, then the bursa is the size of the bursa is more associated with whether they have pain or not, right? So it seems like in an acute injury situation, an enlarged bursa can, be an itis and can be, part of the cause of pain. Whereas often we have enlarged bursae in our shoulder that are unrelated to pain. And so what I would, love if you had would be an MRI or an ultrasound or whatever you got on the sore shoulder, if you got the exact same imaging procedure done on your non-sore shoulder as well, right? Because then we would know, okay, well, you've got an enlarged bursa and you've got a rotator cuff tear. What about the other shoulder? Do you have an enlarged bursa and rotator cuff tear on that shoulder? And what we find is, like, typically in a population, it's very common that people have the same findings in their uninjured shoulder as in their injured shoulder, and therefore those findings don't necessarily explain the pain. Now, I don't know if that's the case for you or not. It sounds like it might not be because you had an acute kind of onset of that situation. But that's something to bear in mind. And then the rotator cuff tear, well, I don't know your age, but, you're over 20 and under 60. If you're like 30 or 35 or whatever, there's a reasonably high proportion, not 50%, but, somewhere in the vicinity of 20 to 30 to 40%, somewhere around there, of people would have degenerative rotator cuff tears, with no pain in their shoulder. You might have had that tear for 10 years, right? And it's just been sitting there totally pain-free, and then your toddler pulls on your arm and causes some kind of transient pain episode, and you get a scan and it's like, oh no, they've caused a rotator cuff tear, but maybe the tear was there all along, right? And that's why I would like to see a scan of your other shoulder as well. Finally, the idea of shoulder impingement really is not a valid diagnosis anymore. The idea of shoulder impingement is basically when you lift up the arm, that the bone kind of bangs into the acromion there, okay? But, or in high class words we say impinges into the bone. And there have been a few significant high-quality large trials recently that have really shown that that's not a thing. Surgery for impingement is no better than placebo surgery. We know that the acromial distance, the distance between the two bones, is no different in people with shoulder pain versus people without shoulder pain. So we don't use the term impingement anymore. Instead, we say subacromial shoulder pain, which is a description of the symptoms, not a diagnosis. Or I prefer Adam Meakin's, the sports physio, his diagnosis, which is something hurts in the shoulder. And he calls it shits. Something hurts in the shoulder. And so that's his diagnosis, because basically the evidence is pretty convincing that we can't isolate shoulder pain to any particular structure, right? And so regardless of what you find on your scans, the best prescription is progressive general strengthening, okay, within pain tolerance, and then address those psychosocial factors that we talked about in the previous question, like sleep and stress and physical activity and blah, blah, blah. But, as to the physical exercise component, I would start with whatever you're able to tolerate in terms of loading. And so it doesn't have to be pain-free. It just has to be like tolerable pain. And I'd say if the pain is elevated for more than a day after you do an exercise, that's probably an indicator that you push too hard. Okay, you should do less intense or less amount, fewer reps next time. But that a bit of pain during and even a bit of pain after is fine, as long as it settles within a day. And that you should start gradually, and you should do some exercises every day for it, and particularly work on the painful ranges of motion, the painful positions, but work on them at a low enough load that it's tolerable and that the pain settles within 24 hours, right? So you might have to reduce the range of motion, reduce the speed, reduce the load to a point where you can tolerate it, okay? And then gradually, build it up over time. Now, if there was an acute injury and it's a tendon injury or a ligament sprain or something like that, well, that might take several months to resolve, okay? So I'd expect it, the progression to be a several months long process. But if on the other hand, it was just a sort of a transient pain episode, because I know that people with toddlers don't always get a great night's sleep, and sometimes life's a bit chaotic and stress happens and stuff like that. So there might be other factors, in which case you might be able to resolve it much more quickly if you can address some. You don't have to make all of them perfect, but if you can address some of those factors to some degree, you might find that makes a big difference. But combined with progressive strengthening within pain tolerance. All right, so we're at time, and thank you very much all for being here. Thank you so much for those of you who contributed questions, and those of you who contributed questions during the week as well. And if you're here or if you're watching afterwards and you have a question, you can come by next time and ask your question, or you can send it to me via email. And we'll pop a link underneath the recording of where you can send your question. And this is recorded. And so if you want to watch the recording of this and all of our other weekly chats, because we do this every week now, you can join our Facebook group, which I'll send you an email about, or someone will send you an email about within the next day or so. If you want to join that, it's free. We're not advertising stuff at you. It's just a Facebook group where you can come and watch the recordings of these and ask questions or whatever. So I hope you have a great week. I'd love to see you again next week, and I look forward to when that happens. See ya.